arthroscopy course would be held on the 5th and 6th of July 2025. Thank you.
Thank you. Everything about the reverse shoulder replacement.
First is a video on hemiarthroplasty for a foot-part fracture. Dr. Oberoi has very nicely given you the overview of how it happens. Let me tell you, we are a compulsive fixers of proximal humerus fracture. Everybody knows proximal humerus fracture means fix it, plate it. And I see so many complications of plate failures, and they are complete disaster. So what is the treatment of a failed proximal humerus fracture, failed fixation? It is reverse shoulder replacement. And sometimes these guys are young, 35, 40, 50, and you can imagine doing a reverse shoulder fixation, reverse shoulder at that kind of a patient. So I think for us to learn hemiarthroplasty still is very important because there is no escape. Though all over the world, the reputation of hemiarthroplasty has taken a downhill, and I have done quite a few, and I'm not that unhappy. And I would say why? Because in most places, all these hemiarthroplasties all over the world are actually done by trauma surgeons. And that is the problem. Hemiarthroplasty of the hip is a trauma surgery. Hemiarthroplasty of the shoulder is not a trauma surgeon's domain. It is one of the most difficult replacement operation. वापिस चलो यार, अभी शुरू नहीं करने का. इससे play कर सकते हैं? Pointer कौन सा है? Okay. So I will just present this, my way of doing it. One basic difference between what Dr. Oberoi told and I'm going to say is I do it by lateral deltoid split approach. For the simple reason that is a God-given approach. You reach there, everything is in front of you. The key to success of hemiarthroplasty is union of the tuberosities. And when you reach directly there, you do no biological damage to the structures, put your prosthesis in quietly, and just close the book. It is all there. Unusual approach, but I'm sure once you want to do something, you do it the way it should work, because healing of the tuberosities is the most important thing for the success of hemiarthroplasty. So this is a case. Chala do bhaiya. Can you just play the video, please? So this is a 7-minute video to show you exactly how it is done. Can somebody play it, please? So this is the position which Dr. Oberoi also showed you. You should be able to hyperextend, and the patient is at the edge of the table. I want to take radiographs all the time. My image intensifier comes from the head end, and I can take radiograph. It is very important to take radiographs again and again. ये चल नहीं रही है. And this is the exposure, the lateral deltoid. This is the video. Why is it not playing? Hello? What stupid? I think maybe the video is not loaded. I'm sorry about that. So we go deltoid split approach, which means, okay, now it's playing. Vapis chal jao. Go back to the beginning, please. शुरू से चलाना है. यहाँ से yes. म्यूजिक भी है इसमें, थोड़ा म्यूजिक भी चला दो. So, okay. अब क्या करना मुझे? तुम चला दो, वीडियो है, चलते रहे. So this is the position, and this is the deltoid split approach. That is the nerve there, and that is the last point. And I mark the anterior acromion, lateral acromion, about 1 centimeter behind. Make a mark with a cautery, because I split the acromion here. And split the deltoid, create a space, put my finger under the acromion, and then make a mark here, which I'm going to split with the help of I save my axillary nerve, so make a stitch there, so you don't split before. Then I cut the acromion there, and that opens up the whole space for me. Just remove the bursa. Usually there is a bursa there because of blood collection. Remove the bursa, and right there you are. The head is visible there, and you get your tuberosity a little bit on the side. They are connected to each other. So it will take a little while. You catch one of the tuberosities. This is GT from the back, You take stay sutures in the tuberosity, no dissection required. It's a God-given approach. Similarly, you take a stay suture in the lesser tuberosity, which is in the front, and then open the door. So these are two tuberosities, that's how they're going to come back. Open the door with the help of a spreader and just deliver the head. So see how much little further damage have you done to the whole area. So it's a very, very biological way of doing it, because if tuberosity doesn't heal, it's a failure. Remove the part of the head which is still attached with the tuberosity, and then you look straight down on the glenoid. You can remove all the small pieces, maybe wash it out, take the blood out, and then deliver the upper humerus through this, find the canal. You can see your version for reamer, and that is the version. It says 30 degree there, and you decide usually 30 degree version, and the broach goes in, and then you have to decide how high it is going to be. Three things: height, retroversion, and size. These are three important things. So in this design, you put this and put it inside and see whether you are right. So I cannot measure 5 millimeter, 2 millimeter on the table. What I do is I just put it back and put my tuberosities temporarily around it. There should be a tension like this. The head should be 50% mobile. And then temporarily tie the tuberosity around that thing, just a temporary fixation, and take an X-ray, image intensifier. So that tells me where is my head. It is not too long. My tuberosity is at the right place. So this is what is the trial stage, and I'm quite happy with this. The whole thing should be round, the head and the tuberosity. So then I open up again. I know if I fix my process like that, it will have a good orientation as well as position. Then we get the real implant in, and all that height and version is all marked. As you can see, there is a cautery mark here. So once on the trial, you decide everything, how deep you are going to go, how version you are going to control with the help of this mark. Then you put a trial head, and again check for soft tissue tension, which means if I push it with my finger, I should not be able to dislocate it, but I should be able to move it 50% on the glenoid. So that is the right kind of tension, and then replace it with the original head. Always smaller head than what you measure. The biggest mistake is sometimes you measure it wrong and head becomes too big. And once that is done, then the rest of it is tuberosity reconstruction. Again, I take a picture temporarily. After you put the original implant, everything should be in place. And then comes the real game of fixing the tuberosities back. And that is a little complicated stuff. It has to take you a couple of sessions to understand which suture is going to go. Essentially, there are two sutures. One from tuberosity to prosthesis, tuberosity to prosthesis. Again, tuberosity to prosthesis, and one goes vertical through these two holes. It takes everything like that. So it is a very comprehensive reconstruction of tuberosity. You can put graft, but ultimately this takes almost half the time of the surgery to get the tuberosities in place, tie them properly through horizontal sutures, vertical sutures, put bone graft. It should really be very sturdy and move very. I use these days fiber tape for these, because sometimes there's even fiber wires cut out. So that fixation is a very important thing, and once you have done that, let me just fast forward this. That's the kind of reconstruction you want to achieve with the tuberosity. And now once the door is closed, you can really reinforce it with multiple sutures. Essential point is that your tuberosity has to be very solidly fixed. Then only they are going to heal up. And then we close this osteotomy of the acromion that I made with just two ethibond sutures. It doesn't make any big difference to the mobilization. And then just close the split in the deltoid, and the job is done. So I think after having done it by deltopectoral as well as this approach, I think this approach gives me the right kind of exposure and very, very biological approach to approaching this surgery, and that is the crux of healing of this case and the success of hemiarthroplasty. Second laga de. So my second talk is on philosophy of reverse shoulder replacement. And this enticed me, what crazy this guy was who decided to reverse the shoulder. This must be somebody actually from an asylum to think that way. That means You put my hand on my leg and say, I'm great and I'm such a great surgeon. So, but it was very interesting to understand how Gramo thought about this. And I made a little presentation on this because I was quite enticed by his way he thought. So normal shoulder is like this. There is a glenoid and the head and the rotator cuff and deltoid. So in simple biomechanics, for shoulder to elevate, two things are important. One is the head has to be centered on the glenoid. And second, once it is centered, the deltoid has to move. Then only you can have abduction. If head is not centered due to any reason, for example, rotator cuff tears, this deltoid can do nothing. So shoulder biomechanics needs this force couple, centering of the head on the glenoid and action by the deltoid. Now you see what happens when the rotator cuff is gone. There is no centering, now deltoid pulls it up. Once it pulls it up, it starts going up, start touching there, and there is no elevation. Also because of friction between these two surfaces, osteoarthritis comes in. That is the crux of all the rotator cuff arthropathy. This vertical force, shear force. So what is required is constraint. What do you need constraint? You need something to keep this head down. If head is down, then everything will work very well. And this was the first thought that came to the mind of surgeons, that we create a kind of a shelf which will keep the head down and now deltoid will work. Very logical idea, but didn't work because constant push of the head would create shear force on this, and this is what ultimately happened. So this shelf business did not work. But there was a need to create a constraint. You do not want this head to go up. This is the experiment number 1 which failed. And this is the kind of process they had devised. Then they came to the idea, okay, I want this head to remain inside. Let me deepen the groove or deepen the glenoid. That's what next idea was. And that was tried also. And this was the process which devised. Again, same reason. One, you are deepening the bone and it will eat up the bone and gradually it will erode this and head will still go up. So even this experiment failed. Then came the idea, why not create a ball and socket joint? Hip joint works very well. So let's create a hip joint in the shoulder. So they had a round acetabulum, a round glenoid and a head, something like a hip joint. But problem was same. There was a deltoid which was pulling it up all the time. Again, this so-called acetabulum failed. They reversed it because some constraint is required. If there is no constraint between the head and the glenoid, it will nothing will stop it from going up. So they created this constraint. Okay, let's reverse this. And this same problem, because there was a force and this also got loosened. Look how surgeons think, amazing. Finally, they realize constraint is required because you don't want to let the head go up. But this constraint has to be such that it is fixed on the glenoid and it should not loosen up. You want, मतलब आम हाथ में भी चाहिए और मुंह में भी चाहिए. So with increase in constraint, why was loosening happen? This was the thought which changed the whole game of reverse shoulder. You have seen why loosening is happened? Because center of rotation is far away from the joint here. This is the place where every failure is happening. And this center of rotation, when you move the arm, creates forces on this junction and that causes failure. So intelligent idea came to idea that Gramo, that why not medialize the center of rotation? So this is the normal shoulder. He thought normal shoulder center of rotation is there, I want to move it medially. And he created this first generation of reverse shoulder replacement, which was something like this. The center of rotation was shifted medially with an idea that forces will not be there, the shearing force, and this will work. And this was the first design of Gramo, something like this. But poor fellow didn't know, you can't fix this implant on a glenoid bone just with one tiny post. It cannot happen. Though the principle was sound, but even this failed. And then he worked on it and he came with an idea of a different Gramo 2, where he fixed the base plate on the glenoid, center of rotation there, and now put a sphere there. So he understands now. Round and round means constraint. Constraint means shearing force, but shearing force is dependent on center of rotation, which he has now put on the right place. Now this is going to work. And that's where the reverse shoulder came into being. So we have achieved 3 goals. We need constraint, that means round and round design. And constraint should not cause shear force. How? COR is close to the glenoid bone junction. And improved fixation technique here added to this part not getting loosened. The movement of center of rotation there and proper fixation using a base plate made the thing work. And that's where reverse shoulder has come into the beginning. Reverse shoulder is now the most popular shoulder operation. I'm amazed how the whole world is going crazy. It is now 65% of the shoulder replacements. Not hemi-arthroplasty, not total shoulder replacement, reverse shoulder replacement. And I've told the companies 225 is going to be a year of reverse shoulder replacement even in India. Lots of hips and knees have been done. Now it's the time to do reverse. So what is the issue with Grommo design? Still, there are movements happening. Issue was this centralized, so all the rotator cuff in the front and back, they become loose. So they lose rotation. Though there was good elevation with this design, but rotation wasn't there. So if you lift your hand, it will drop like this. You can lift it like this. So now again, thought came, what to do with this? And the concept of lateralization came. I mean, I will not go into too much detail. This is a little bit high funda reverse shoulder replacement, but so it is improving every day. But the basic concept that if you restrain the shoulder, and this is the picture to learn. You restrain, and all this becomes, constrained joint with good fixation, with COR there, is what made reverse shoulder work. Thank you very much for your attention.
Thank you, Dr. Maheshwari, for an enlightening talk. May I request Dr. Mukesh Ladha to talk about the bio RSA indication and the result.
So we'll move one step ahead after understanding the philosophy of reverse, how to perform the reverse. We have even seen the complication of reverse. Now we'll move one stage ahead, how to do complex reverse shoulder replacement elegantly and with less complication. Bio reverse is bony increase offset. As Dr. Maheshwari has told, Grammot design was an excellent design, but it has medialized the joint center. And that was the problem. It was causing notching, loss of rotations, even the loss of deltoid contour. It was also adding to instability and dislocation. Then came the concept that we need to do something where we can lateralize the center a bit, but not compromising the stability of the component. So let's move ahead. Okay, so this is what we want everyone, that the ideal indication of the reverse shoulder was developed for cuff tear arthropathy. My own patient, which I did 8 years back, patient has excellent function, but you see the 8-year post-op X-ray, you will see the inferior scapular notching. This is again because of the medialization, because of the stem, which was 155 degree. And that's the reason where it causes notching because of medialized center and 155 degree stem. And we all understood that's the Grammot design where you have medialized the center, 155 degree neck shaft angle, which resulted in notching, reduced rotations, reduced abduction, instability and contour. And there comes the concept of lateralization in reverse shoulder arthroplasty, which will prevent inferior scapular notching, which will improve the stability by retensioning the residual rotator cuff tissue, which will invariably help you to get rotations as well as good deltoid wrapping. So you can do lateralization either on the humeral side, because we have now modular tray where you can shift the tray medially and the stem automatically goes laterally, or you can do lateralization on the glenoid, or you can do it on the both sides. But you rarely need on both the sides. So you can increase that offset either by increasing a metal augment on the glenoid, which is called as MIO, metal increased offset, or you can put a bone graft on the glenoid and you can do bony increased offset. So various designs have been there in the market with onlay, inlay designs, various glenospheres are there. Now every company is thinking much on how to get an augmented glenoid, especially in the superior surface, to maintain that inclination as well as lateralization. So lateralization and distalization is the key for reverse shoulder replacement. So how can you lateralize on the humeral stem? As you can see the 155-degree stem and the 135-degree stem, you can see there is a 20 mm lateralization. So from 155, we have shifted to 135, and even with 145-degree neck shaft ankle with an onlay of flushless system where you can lateralize the stem. Rheumatoid arthritis lady, where you can see there is a significant superior glenoid and medialized glenoid loss. So this is an exotic system where they have an augmented base plate, where I have used the superior augment and I have lateralized and I have given inclination. And you can see that the patient develops, so the patient have good range of movement and rotation as well. Another patient who had a very severe glenoid bone loss anterior-superiorly, as you can see that intraopic, you have an augmented base plate where you can have inclination as well as retroversion as well as lateralization. There are some companies which also even allow you to move the glenosphere 2 to 6 mm distally to avoid inferior notching. So this is what metal and bio. Metal has its own advantage, and the bio RSA has the problem of bone resorption, but metal have increased torque which may lead to loosening. So as I told you, if you see the normal glenoid also, it is not a flat surface. So you need to have an augmented base plate either superiorly or lateralized so that you can lateralize the center of rotation. What you do in such bad rheumatoid arthritis patient, if you put your glenoid so medially, it will fail soon, as shown by Dr. IPS Oberoi sir. You can't put and you have a good hold. So you need to put some bone or metal to lateralize as well as to create biology. And here came the concept by Dr. Pascal, who have used this special reamers, which gives him an bone cut, which is little trapezoidal and triangular, and that is called as angled bio-RSA, which also lateralizes the center of rotation. Various classification of glenoid bone loss are there. I'll not go into detail of it. A case example, a young female with a very severe rheumatoid arthritis, you can see how medialized the humeral head has gone. It has gone medial to the lateral end of acromion. So if you fix your reverse shoulder in this position, it is definitely going to fail because you have no purchase on the on the glenoid. So you need to do here bio-RSA. I have used here iliac crest bone graft revision base plate, where at least 10 mm should go into 15 mm should go into the original bone and 10 mm in the graft. You need to have hold in the coracoid because that's the strongest bone available, and then maintain the inclination and distalization, and there you see that it completely heals. Even you see the movement of the patient, full forward elevation, abduction and rotation. This is the CT scan 3 months post-op. It shows complete union of the bone graft, and patient is able to do all activities without any problem. So that's the beauty of lateralization and distalization. Does 145-degree on the stem gives you good result? Yes, it increases the external rotation, and the graft resorption rate is not high. It is as much as 90% in bio-RSA. Another patient where you have a concentric bone loss on the glenoid and you have a humeral head. It's difficult to have those specialized instrument in our set. So before you do osteotomy, just remove the whole of the cartilage, and you can use that same humeral head to fix that concentric glenoid bone loss. As you can see on that X-ray, that how beautifully it sits and it reabsorbs well. You need a strong fixation, not only 2 screws, sometimes 3 screws, and a little longer proximal screw which takes hold in the coracoid to avoid that graft resorption problem. And you can see it completely heals. So the problem which takes care by this bio-RSA is the scapular notching has reduced drastically, prosthetic instability is 0, and glenoid loosening is also 0. So that are the major advantages. Again, meta-analysis shows that they have very good incorporation and loosening rate of only 2.4%. A gynecologist, again primary OA, you do a good reverse shoulder replacement with a bony increase offset, and being a very fitness enthusiast patient, he can do everything within 6 to 8 months. Though you say it should not be done, but an enthusiast patient. And last and not the least, You have a failed reverse where there is severe bone loss on the glenoid. You have only bone which is left in the anterior half of the glenoid. When I opened it, there was nothing posterior superior, posterior inferior. Again, you can use a bony increase offset. Use those two proximal screws in the coracoid, which will give you excellent hold, and you can see that this is immediate post-op, and for few months, you can see the whole incorporation of the bone graft. So increase lateralization and distalization is the key for successful reverse shoulder replacement. Thank you.
Thank you, Dr. Mukesh. May I request Dr. IPS Oberoi to come on stage for the panel discussion, and I request Dr. Wakankar also to please come on stage, please.
Sir, apni
If there are any